Hello, I am Dr. Stephen Su, a board-certified ophthalmologist, and I would like to explain the various steps of cataract surgery so that you, as the patient, can understand the operation that will help you regain your sight. As you know, a cataract is a clouding of the natural lens that occurs as we all get older. Since this lens sits behind the iris, the colored part of the eye, and the pupil, all images must pass through this lens and onto the retina. If this lens gets hazy, then the image quality will be decreased, and you will not be able to see your potential even with a change in your glasses or contact lenses. Imagine your view through a dirty or soapy window. Common symptoms of cataracts include cloudy or blurred vision, halos and starbursts around lights making it difficult to drive at night, the need for more light to read, and an increase in light sensitivity. In this video of one of my routine cataract surgeries, you will see me using an instrument that breaks up and removes your old lens material called phacoemulsification, and then you will see me insert an intraocular lens implant, or IOL, that is about 6 millimeters in diameter. I tell my patients that cataract surgery is a remove and replace procedure. After we take out your cloudy lens, an artificial lens implant that is made of either silicone or acrylic is placed into the thin, transparent lining or capsule of your original lens. Without the IOL, you will lose a large amount of the focusing power of your eye. I often tell my patients that if you had a knee replacement surgery, the orthopedic surgeon will not just remove your old knee and close up the incision. They have to put in a knee implant to restore your leg's functioning. The nice thing about the IOL is that we can target your vision for distance or for up close. You will have this discussion with your ophthalmologist at the time of your cataract surgery consultation. Some patients with astigmatism, which means your cornea is shaped more like a football than a basketball, can upgrade their implants to a toric IOL to correct this condition. Multifocal IOLs can correct astigmatism and give you near and far vision without necessarily resorting to glasses. Before surgery, we measure your eyes to ensure that we place the correct IOL to get you the result that you desire. At the surgery center or hospital, an IV will be placed to give you some mild sedation to help you relax. The ocular anesthesia is done either by injecting lidocaine, a numbing medication, around the eye, or by using topical anesthetic drops. Patients are generally comfortable throughout the short procedure. If we use the anesthetic injections, we will put you to sleep for a few minutes so that you do not feel or remember this part. Then you will be brought into the operating room where the nurse will prep your eye, eyelids, and surrounding skin with a cleansing and sterilizing solution. A sterile drape will be placed, and a metal lid speculum will help keep your eye wide open throughout the procedure. During the surgery, more IV sedation can be given if you are not relaxed enough, but we do not want you too drowsy because we need you to cooperate with us and not make any sudden movements. Let's go ahead and start the video. It is in real time and it has not been edited. As you can see, the metal lid speculum is already in place. The surgery begins with the first of 2 incisions. This one is called a paracentesis, or side port incision, and is about 1 millimeter in width. Since we use topical anesthesia in this case, I am now injecting some lidocaine into the eye to help minimize the patient's discomfort during the surgery. Here I am injecting viscoelastic material, which is a clear and colorless viscous substance that helps to keep the eye inflated during the procedure, and it helps to protect the delicate inner layer of the cornea, called the endothelium. I am making the main incision here, which is usually less than 3 millimeters in width. In this case, both blades were diamond blades, so obviously they are extremely sharp. It is important to make a smooth, beveled incision so that it can close spontaneously after I am done. We call this a self-sealing incision. I inject more viscoelastic into the eye so that it does not collapse as I insert and remove instruments from the eye. This is the cystotome, which is a bent needle used to puncture and initiate a tear in the capsule of the lens. I complete this opening with Utrata forceps. I told patients that this is an extremely important part of the procedure and that they need to keep still by staring at the light. Any sudden movements during this part can make the rest of the case more difficult. It is vital that this is a continuous circular opening to maximize its stability. This opening will give me access to the parts of the cloudy nuclear and cortical lens material that need to be removed. Next, I use a syringe with a cannula to inject a special saline solution that loosens up the cloudy lens material from the capsule. This will enable the cataractus lens to rotate more freely in the capsular bag. In the United States, virtually all cataract surgeries are performed with this small incision technique using ultrasonic energy called phacoemulsification. In some other countries where access to phacoemulsification is not available, cataract surgery involves making a bigger incision so that the nucleus can be removed in one whole piece. Because of this larger incision, the healing time can also be longer. This phacoemulsification needle is a hollow tube that uses the ultrasonic phaco energy to vibrate tens of thousands of times per second to break up the lens material and then suck it out of the eye. I first made a groove in the nucleus, which is the densest part of the lens. I then introduced this second instrument called a chopper. By using these two instruments, I'm able to break up the cataract into 4 smaller pieces. The phaco energy and vacuum are controlled by a foot pedal. The harder I press on the pedal, the higher the energy and the vacuum levels. So after the cataract is divided, I am able to remove the pieces out of the capsule. I would consider this a medium density cataract. More dense lenses will usually take more energy to break them up. So after the nuclear material is removed, the automated irrigation aspiration unit, or INA, is used to remove the cortical material, which is adherent to the inside of the capsule. So this is the layer between the nucleus and the capsule. Unlike the phacoemulsifier, ultrasonic energy is not needed because this material is soft. And this is also controlled by pushing down on that foot pedal. Sometimes I power wash the capsule using the saline solution to loosen up the fine strands of cortex. Now you can see that there is a clear capsule. This intact capsule is the reason that the intraocular lens implant, or IOL, does not need to be sutured into place. I am injecting viscoelastic material into the capsular bag to inflate it so that the lens can be inserted without causing damage to this delicate lining. Here you see the tip of the cartridge of the IOL inserter. The artificial lens gets compressed in the injector and will open to its full size inside of the eye. This way we can keep the incision size small, which reduces surgically induced astigmatism. There are 3 parts to this IOL: the 6mm silicone optic, which is the part that you see through, and the 2 fairly rigid blue curved haptics, which are the leggings that keep the lens centered within the pupil. Acrylic is the other material commonly used in IOLs, and this metal instrument was used to place the trailing haptic into the capsular bag so that the IOL centers correctly. It's necessary to use the INA instrument again to remove the remaining viscoelastic substance because it does not get cleared easily by the natural drainage system of the eye. If too much of this viscous material remains, then there may be high elevations of the eye pressure postoperatively. This maneuver is called stromal hydration, where I squirt the saline solution into the edges of the incisions to create some temporary corneal edema to help with spontaneous closure of these incisions. If these incisions self-seal, then I do not have to use sutures to close them up. I check the incisions multiple times to ensure that they are indeed sealed correctly and that the eye pressure is within normal range. Proper sealing of the incisions will greatly reduce the risk of a post-op infection. That is the end of the case. After the lid speculum and drapes are removed, an eye shield or patch is placed on the eye until we see you in the morning. I hope this helps your understanding of cataract surgery, and I hope this has calmed some of your fears that you may have had. Thank you again for watching this video.